We're going to talk about burns. Big thing about burns is skin destruction, obviously. So you got to think about what the skin does, right? So what kind of things does the skin do? Let's see here. Function of the skin: it's a protective barrier, keeps pathogens out, right? Temperature regulation, very important in temperature regulation. This is where you get the vasodilation and vasoconstriction. It's where you get the sweating, right? These are the things that happen there in the skin. You have thermal receptors in the skin that send the messages up to the thermoregulatory system, all that stuff. So you lose a lot of temperature regulation in whatever areas are burnt if you've burnt down into the dermis, and especially if you have a 3rd degree burn that goes all the way through the subcutaneous layer. Let's see, sensory, right? If you destroy all of the nerve cells, the nerve endings, you can't feel anything there, right? Let's see, keeps water in, right? We always think about keep stuff out. Jump into a pool, right? It keeps all that water out so it can flow through your system, but also keeps the water in. When you have a burn, huge thing is that you're going to have a more insensible water loss because more water is going to be evaporating out through that compromised skin. The subcutaneous layer, a lot of cushioning going on there, so you lose that. Without the cushioning, you can end up with more ischemic damage and things like that down the road. So there's a lot of things. Another thing is the elasticity. If you burn down through the second layer, the dermis, you lose a lot of that elastin protein that's in there. So the elasticity of your skin is going to be compromised. So I've got here a piece of this diagram of skin, right? You've got the epidermis top, very thin layer, goes over the top of our skin, right? And it's mostly dead tissue. Let's see, let's get sunburn. There's 5 layers there, but all together, they're only like paper thin. I mean, it's just this top layer of our skin. Maybe thick construction paper thin. But anyway, that there, you get the blood supply that comes down from below. It only gets to that bottom layer. So it's where it's all the reproducing does. There's no skin reproduction going up in the other 4 layers of this superficial epidermis here. So that reproduces, and then the layer pushes up, and reproduces some more, and the layer pushes up. Reproduces more, and the layer pushes up. So the further up they go, the drier and deader they get, right? Till the top layer is very flat and dead. So if you only get a burn, a superficial burn, 1st degree burn, it only involves this layer, this epidermis. So it's not a real big deal. It's going to be painful because the nerve endings, which I did in green here, they only come up to there, but they come up to there. So you will feel it. It'll be painful, it'll be red, because it also gets inflamed, right? So you're going to get redness, it's going to get, and it's going to get really painful. Increase blood supply right underneath here from the inflammation. But then if you get into a 2nd degree burn, and they don't really call them degrees anymore, this is just called a superficial burn. This one here is called a partial thickness burn. It means a 2nd degree burn. So there's superficial partial thickness, which is the top part of the dermis, right? Let's go through this. You got the epidermis, you got the dermis, and the hypodermis, which is also called the subcutaneous layer, which I have here in orange. That's just made up of fat, right? And it's before you get into the muscle down here, and then you got your blood vessels down here feeding into the muscles and feeding up there. So superficial partial thickness is the upper portion of the dermis. Deep partial thickness means that you've involved the lower portion of the dermis. And 3rd degree burn, or full thickness, means that you've also burnt the subcutaneous layer. And there is what they call a full 4th degree, which means that you've burnt the muscle and bone down below that too. So if you look what's in here, try to mark about hair. So your hair is all in the dermis. So when the dermis is involved, that's what you're going to be losing, and stuff like that. The circulation, right? So because the dermis is involved, you'll get blisters, right? You can get blisters in here because you have the capillary beds coming up into there. This is no blisters up here, just redness. Second degree, you get blisters. And there's also sebaceous glands and sweat glands. So if you lose your sweat glands and you lose your sebaceous glands oil the surface. That is important for making a watertight barrier, right? So when you lose that oil, you can lose water, can evaporate out of your system, and water can enter into your system easier because you've lost these sebaceous glands. You don't have that nice oil-coated layer. Nerve endings are in here, so it's going to be painful. So you're going to have blisters, it's going to be painful, and it's going to be moist because this is a moist area and it has a blood supply which brings in the plasma and all that stuff. Let's see, so sebaceous, and then you get down here, subcutaneous, which is also called the hypodermis. That's the orange layer here. First degree, red and painful. Second degree, blisters, painful, moist. Third degree, when you get down here in third degree, you burnt through all three layers there, all the way through your fat. You've lost your circulation, right? So you probably won't have blisters. You burn all of the nerve endings, so it won't be painful. Now, that doesn't mean that you can smack them around and they don't feel anything, right? You get a burn right here, this whole area, maybe you got a white spot right there. Third degree burns will usually be white because there's no circulation to them. They might be a dark brown or black too from the burn itself, the eschar from the burn. But a lot of times they are white. And when you push that area, it's a leathery and hard, and you push on it and they don't feel it. They might say, ooh, but they don't. I mean, usually when you touch a burn, it's like, ouch. You push on it and like, oh yeah, that hurts. Well, they're not feeling the pain right where you're pushing usually, but it's like around the area because the pressure from pushing there. You can definitely tell the difference. So the painless. So that's the thing about third degree. Dry, painless, white or black. It's not normal pink, and it will not blanch at all, right? Because you don't have any circulation into that area. So now I want to talk about what actually happens when you have a burn, right? Let's say I burn a spot here in my arm, right? Touch the stove or something. So you burn this spot here. Underneath where you got those capillary beds, right? You got the capillary beds coming up in there. They get destroyed, right? So now, let's say this is second degree. So in that spot there, the capillary beds were destroyed. And now if you remember how fluid moves through our system, I'm going to go through it real quick just because I know that a lot of you probably don't remember from the first day of class or the first week of class anyway. But our fluid comes in the capillary bed. Hydrostatic pressure from the heart pushing it, and it goes and it moves out of the capillary beds through slits in the walls, and the fluid moves out there and takes sodium with it, takes potassium, takes oxygen, takes glucose, right? Small proteins, right? It moves back in there, but it doesn't take albumin. Albumin is too big to fit through those slits. So albumin doesn't go through. So now you've got all this stuff going down through the capillary bed, right? I'm an albumin, I'm going down there, I'm in the blood stream, and I'm coming down through there, and I see through these slits in the walls when I get down to the capillaries, I see the plasma getting pushed out into the interstitial areas. I see, sodium and potassium and glucose, all these things getting pushed out there, but I can't fit there, so I just keep getting pushed through the capillary beds. I get over to the other side, now I'm over here in the venous side, and the fact that I'm there, I'm a solute, I'm something. I create an osmotic force in the venous side, and it pulls the fluid back into the veins, right? Albumin is like a big sponge. It pulls fluid towards it. So it gets pushed through, and it pulls the fluid back out of the interstitial area, back into the venous system, and that's how you get your fluid exchange. Fluid gets pushed out, and then it gets pulled back in by osmosis. Pushed out by hydrostatic pressure, pulled back in by osmotic pressure from albumin. Now, with a burn, what happens is the capillary beds are destroyed. So as albumin's going down through there, the slits are off there, right? There ain't no slits, just great big old gaping holes I get pushed out into the interstitial area, right? I get pushed out there with the plasma and stuff. So now what happens? I'm changing the whole osmotic pressure here in this burnt area, right? I burnt right here. Well, now I get albumin out in the interstitial area, pulls more fluid towards me. So it's pulling more fluid into the interstitial area, right? The tissues in the skin, pulling more fluid in there. So what happens? The fluid gets pulled in that area and pulled in that area, end up with a big old blister, end up with third spacing. Third spacing is when fluid gets moved into an area where it doesn't belong. It doesn't normally go there. Not that it can't, but it doesn't normally go there. And it's hard for the body to reabsorb things from third space. Well, now we've pushed this fluid up under in here, and we've got a big old blister there. Right? So that's what happens. Now let's take that same scenario and say my whole leg, right? My whole leg here is burnt, right? I don't know what I did. So somehow I burnt my whole leg. But usually, I don't know, stepped in a fire or something. Burnt my whole leg, right? Your leg, that's 18% of your body, right? 9% on both sides, we'll say. I burnt both sides of my body. So now, that's a big area that's burnt. When I was talking about the little spot here where I touch it on the stove, not too big a deal, get a blister. Now down here on my leg, all those capillaries in my leg are burnt and destroyed. So the fluid goes, so that my circulation goes down in there, and I lose albumin into the interstitial spots all over in that great big huge area. It pulls fluid towards it. Not only that, as more and more goes down there, I keep losing albumin into that area. I end up without enough albumin in my system, right? So now I'm low on albumin. So what does that do? Well, we just talked about how fluid shifts out of the vascular system into the interstitial spaces and then back in to the vascular system. Well, we're missing the albumin. We don't have enough albumin. So over my entire body, I'm not pulling fluid back into the vascular system. It's shifting out. So as all this fluid shifts out, even though my face isn't damaged, fluid shifts out and it can't get pulled back because I don't have the albumin circulating in the capillary beds to pull it back. So I get puffy face, puffy eyebrows, puffy fingers, even though it's my leg that's burnt. I'm puffy all over the place. And that's because I'm missing albumin, and now I've got fluid shifts all over the place. What's the danger of that? The biggest danger of that, hypovolemic shock, right? Your book called it hypovolemic shock. I always thought of it as a distributive shock because the fluid is there, but I don't know, exactly the same problem. But so anyway, you've lost this fluid out there. Another thing, this whole area, it's been destroyed, my sebaceous glands and all that stuff, so I'm losing fluid just by evaporating out of there. And you can lose a lot more, insensible water loss through an area like that than what we are supposed to be losing. So I'm losing fluid. That's a good reason why we can call it hypovolemic. So I'm losing fluid and I'm shifting fluid out of my vessels into my interstitial area, and I can't get it back. Could even end up with ascites, right? From the lack of albumin. Some other problems that go along with that. Well, first of all, let's talk about hypovolemic shock. I'm backing up again. Hypovolemic shock, what's the biggest thing you're going to have to do to try to combat that? Fluid challenge. We're going to have to give them a lot of fluid, and we're going to talk about the Parkland fluid formula as to how much fluid we're going to get, but we'll get to that in a minute. Another thing, when you've got all this stuff on, you've got all this fluids shifting, you've got your electrolytes shifting, you've got a lot of cell damage, so you got potassium being released into the system, so you can get hyperkalemia. Right? So they better be on a heart monitor, because you've got to watch and see what their heart's doing, because now their potassium is going to be going up through the roof from all of these cells. Because remember, inside a cell we got like a potassium level of about 140, whereas outside the cell we're at 3.5 to 5. huge difference there. You start destroying cells, boom, that potassium level goes up fast because we got a lot of potassium inside our cells. Not much outside them, but a lot inside them. So that's always the big danger. Whenever you have a lot of cell destruction, and with burns, you get a lot of cell destruction. Free radicals are formed. Free radicals mean that they're charged particles. So you get a lot of these free radicals out there floating around. You end up with red blood cell destruction. You got red blood cells going down into that damaged area. Lots of enzymes out there being released, intracellular enzymes. Lots of your white blood cells are going down there and they're releasing enzymes. So red blood cells end up getting destroyed. This is a very dangerous period right after a burn. So these red blood cells get destroyed, and they can get to the point where you actually you have hemolytic anemia, and you actually get sludge. Right? There's so much crap in your blood system, including the red blood cells that are all dying, and all of this other stuff. Right? So you can get sludge. So you have to watch for ARDS. Right? That's one of the problems that you can end up with. Big one though, on the acute here, a big one, and more likely, almost for sure likely, if you don't get the treatment going fast on the fluid replacement, and that is acute kidney injury. You gotta watch for that. Stick a Foley in, you gotta make sure that they're peeing, because when we start doing the Parkland formula, that's a place to start. After that, you wanna see what the urine output is, and you're gonna titrate that fluid. Your fluid is actually started on the Parkland, but it's not a hardcore, this is a rigid process and this is how much you're going to give. No, it's going to be titrated depending on their fluid output. But Parkland gives you a place to start, and it's a lot of fluid that you're giving. But anyway, you get back to the kidneys, you get sludge, goes in there, can block off the nephrons, and fluid doesn't get through there, so your urine output goes down, and you also end up with nephron death. You can lose a lot of nephrons or nephron destruction because they're not getting circulation to that. Also, whenever you have decrease in perfusion, kidneys is one of the guys that are the most sensitive to it because it takes a lot of energy to run a nephron, right? There's a lot of pumps in there. They're very sensitive to the loss of oxygen supply. So when you get a decrease in perfusion plus sludge going trying to get through those glomeruli, you are really doing a number on those nephrons. So that's one of the things. Fluid replacement will help with that a lot. Chest expansion and contraction. If they have a thoracic burn, yeah, I took care of a guy that one time he dumped gasoline all over himself and burned himself. And anyway, he had a thoracic burn all the way around him, right? And his rise and fall of his chest, it had no give. When the paramedics came in, and flight nurse came in, they had cut him, and they call that an escharotomy, where they cut through the skin, and they got a certain way. I think it's like a 2 panels they'll make here, and then when it rises, it can rise and fall again, and the person can breathe. They also will do an escharotomy a lot of times if they burn circumferential all the way around one of your limbs, they might have to cut it. They'll either cut it in one place or in 2 places and cut through that outer portion of the eschar, which is hard from the burn, and then that way it can expand and allow circulation past that area, preventing a compartment. Now let's talk about the rule of 9s, right? Hopefully you can see that thing there. Yeah, I think so. The rule of 9s. They're really easy. The whole head is 9%. So the front, your face, front half of your head is 4.5%, back half is 4.5%. Whole head, 9%. They call it the rule of 9s because it's real easy to remember that way. It breaks everything up in 9s. So 9%. You got 9% in your upper chest, 9% in your lower area, the abdomen. So 18% for this whole area here, right? 18% for that whole area there. So you got 9, 9, 9, 9, 9, right? And then you come down here and you got 9 on the leg. Anterior portion of the leg, 9 on the back portion of the leg. So the entire leg, front and back, is 18%. Now each arm is 9% for the entire arm, 4.5 for the anterior side, 4.5 for the posterior side, right? So, and then, so you got 11 nines. That's 99, right? You got 1% left. That's the perineal area, right? So you got 9, 9, 9, 9, 9, 9 on the leg, oh, I fall over, 9 on the other leg, 9 on the posterior leg, 9 on the posterior leg, 9 on this arm, 9 on that arm. So all these 9s. When you count them up, if you're taking a test, trying to think, is it the whole arm or is it the back of the arm, or is the whole arm 89%? Is it just the anterior surface of the leg is 9? It's hard to remember that, right? Just count them up, right? Right. So you got 9. That's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 nines. So I got it right. All of those, I counted them right. So then you'll know, okay, I counted them right. The whole arm is 9. Or just the anterior portion of the leg is 9. Right? If you do all that stuff, you should be able to figure that out pretty easily. So now we go with the percentage. So when you're trying to figure it out, and you're going to have questions like this, person's entire arm is burnt, blah, blah, blah. What's the percentage about? Well, it's 9, right? Or you might have to figure out how much fluid to give them. Well, that is going to go by how much area is burnt and how much the person weighs, right? So now we'll talk about the Parkland formula, how you figure out how much fluid to give them. Now when you figure out the Parkland formula, you're given all the numbers except one, and that's 4. Because you have to take their weight times 4. So you have to be given their weight times 4, and then times the percentage of body surface area. The whole arm, it'd be 9%, right? So then you would figure out 4 times the person's weight in kilograms times the percentage, right? There's no points in that. It's not like 0.9, it is 9. If it's 9%, it's 9. You multiply it by 9. So let's say you got a person, I'm not going to figure anything out. Let's say you got a person, I think your book had one in there. The person is 70 kilograms. So you go 4 times 70, and they burnt their arm, and let's say their upper chest. So their entire arm and their chest here. So the entire arm is 9 and the chest is 9. Now if it was the whole front, it'd be 18. But what I said, just the chest. So you got 9 here and 9 there, so that's 18. So times 18. So let's figure that out. 4 times 70 times 18 equals 5,040. So let's just round that off to 5,000. So 5,000 mLs over 24 hours. Now you don't just give it over the 24 hours. Here's what you got to remember. The first half of that amount goes over the first 8 hours. So 5,000 over 24, so you give 2,500, that's half of 5,000, over 8 hours. How do you figure that out? 2,500 divided by 8, right? Let's see if I can do that here. So go 2,500 divided by 8 equals 312. So you're going to give 0.5. So you're going to give 313 mLs per hour per hour times 8 hours, right? The second half of this 5,000 is going to go over the next 16 hours, right? So it's going to be slowed down. Now, you know that you're going to give it over twice the amount, so you could just take that 313 and cut it in half if you wanted to. But we'll say we got 2,500 mLs left over 16 hours. So now, we already know what it's going to be. It's going to be half of that. It'll be 157 or something like that. So let's see, 2,500 divided by 16 equals 156.25. So 156 mLs per hour times 16 hours, right? So that's the Parkland formula. Now that's how you're going to start your drip rate, right? You're going to start at this 313. When you get up to 50% burn, you're talking some big fluids. Let's say you got, instead of a 70 kilogram, let's say you got a 100 kilogram person and he's got 50%. I mean, that's going to be huge. So don't be afraid of these numbers. Sometimes these numbers are huge. They're like 700, 800, 900 an hour. I mean, they can be huge. But you go by that Parkland formula. And you start by that Parkland formula. You have a Foley catheter in there and you watch the urine output. You're going to increase that fluid rate if the urine output drops too much. You're going to decrease that fluid rate if their urine output is too high. So you're going to have a window there to watch them. But anyway, this is how you figure out the starting area, right? 4 times the kilograms body weight times the percentage over 24 hours, half of that over the first 8, the other half over the next 16, right? That's how you get your formulas. That's how you get your fluid rates.